I'll always go back and take a look at the previous labs, question of the day, and clinical themes, just so that you've had a chance to read on those a little bit. So we'll just real quick go through. You should know those collateral connections that we have. So we have on the venous side important connections, important anastomoses that allow us then to distribute blood in a cable kind of shunt matter. And then as we'll see, very importantly on that venous side, portal cable connections, anastomoses that we have. So you should know those. Those are very important connections to get blood back to the heart by alternate routes. Also taking place on the arterial side. So as you start doing your dissections and we're looking at these major vessels that are supplying the GI tract, we have foregut, midgut, hindgut, right? We have celiac trunk, it's giving off branches. We have superior and inferior mesentery. There are connections between branches within each of those, three unpaired, and also between them. So start paying attention to those connections that we have. And realize that there's a lot of variability in the cadavers with regards to the blood supply. So when you start looking for particular branches, realize that they may come off of different locations. They'll still name them based upon where they're distributing, not necessarily where they came off. So those are important. And we're starting to get to the point now where we can start pointing to specific structures like the periumbilical veins that we talked about as being a connection to the periumbilical plexus that was a connection between the portal and cable system. Premasteric reflex involves what nerve?
The genital nerve? No, the genital nerve from the genitofemoral nerve.
Genital branch of the genitofemoral for the motor innervation to the cremaster muscle, right? Sensory information from this upper medial aspect of the thigh is going to be from L1, right? What nerve or nerves would supply that area cutaneously? Ilioinguinal, genital branch of the genitofemoral also. And if you went a little bit anterior, the femoral branch of the genitofemoral supplies the anterior aspect of the thigh just below the inguinal ligament. So, any of these L1, maybe even L2 levels could potentially cause a reflex in that area. And what's the function of the cremaster muscle normally? And why would you want to do that?
Temperature.
Temperature regulation, right? Spermatogenesis needs to take place at a slightly cooler temperature compared to the body core. So the testicles are housed outside in that scrotal sac, and then we can regulate bringing them closer to the body if they need to be warmer, or away from the body if it needs to be cooler. What else helps the cremaster muscle? Dartos muscle. Okay, so dartos muscle actually is smooth muscle in the scrotal wall, right? Which also, when contracted, will push the testicles closer to the body. Okay, so those things. Hydrocele, hematocele, that's something that we haven't really looked at. This tunica vaginalis, this encasement of the testicle and most of its aspect by this diverticulum of that peritoneum. But be aware of that this is a vaginal process. The diverticulum of the peritoneum normally will bleb off and then become a closed sac on its own. And if there's excessive production of serous fluid, you'll end up with this hydrocele. Indirect. So now you've got a chance to really look at the deep inguinal ring area since we've opened up that peritoneal cavity. Okay, any questions, any problems with these? Those are good. All right, let's take a look at today's then. Okay, today a patient has a perforated gastric ulcer. When the abdomen is open, the gastric contents are observed in the main peritoneal cavity. That's the greater peritoneal sac. Right? However, there's no visible perforation on the anterior surface of the stomach. How did these gastric contents reach the main peritoneal cavity? This is pretty easy, right? So we have really two major portions of that peritoneal cavity, right? We have the main, this greater peritoneal cavity, and we have a lesser one, right? The lesser peritoneal cavity or sac. Omental bursa, same thing. What's the connection between the two? We still have this continuity, but they're only connected now because of development, the way things have rotated and been packed back into the abdominal cavity. We have actually a peritoneal cavity that's divided up now into this greater and lesser portion, and they're still connected by what? Did anybody put their finger through it today? Epiploid foramen of Winslow, right? So this is actually the only connection between this little pocket, this omental bursa, and the major, this main peritoneal cavity or sac. But it's still all continuous. But so in this particular case, we have an ulcer, right? And it's ended up dumping contents into the peritoneal cavity into the omental bursa, which made its way to the main cavity through that little doorway. Ascites, what's ascites?
Fluid in the abdomen.
So fluid in the, how would it get there? What would cause excessive fluid production?
Too much.
Clues?
Trouble with the lymph.
Pardon?
Trouble with the lymph.
Maybe, yeah, you've got, cirrhosis, maybe. Liver disease might do it. Pancreatitis. So you get excessive production of fluid in that area, or fluid getting into the peritoneal cavity in some manner. Turn that off. Pneumoperitoneum. Now we got what in the peritoneum? Air in there. How did air get in?
Puncture?
Yeah, so there's some kind of perforation of the GI tract, right, somewhere. So that could happen. How would that happen? Trauma, maybe, right? What else might cause it?
Severe ulcer.
Yeah, so we just talked about a gastric ulcer, so we actually perforate the wall. So we get air along the GI tract. Could be from surgery, somebody after doing surgery might accidentally poke. Pardon?
If you poked it a hole in the stomach, wouldn't you be worried about the acids that are going to get into it?
Well, yeah, you've got evidence of air getting in there, but yeah, you'd be concerned about other things getting in, right? Perforate the bowel, you're worried about feces getting into that and spreading infection throughout there. So this happens to be air that got in there. We have to find out what happened, why that happened.
Sword swallowing. Sword swallowing.
That would do it. Okay, hysterosalpingonography. There was a picture in here, this photograph. Okay, this is actually a radiologic procedure. Go into the vaginal area and inject, radiopaque dye and then trace it, with imaging. So that's the uterus. And you can see these little kind of strings coming off of that. That's the fallopian tube. So hysterosalpingography then is a way that we can actually look at the patency, if these fallopian tubes are open or if there's any blockage. Now, what's happened out here?
It's not into the peritoneal cavity.
How did that happen?
So
Is that
it
bad or
punctures.
is that normal or what?
It's bad.
And that's not abnormal.
Isn't there normally a gap between the ovary and the fallopian tube?
Yeah,
So it can-
the ovaries, the egg from the ovary has to traverse the peritoneal cavity. So the fimbriated ends of that fallopian tube are open in the peritoneal cavity. So unlike the male, in the male, the peritoneal cavity is kind of closed off. But in the female, that peritoneal cavity is essentially exposed through the vaginal area to the exterior. So when the vagina, the uterus, and the fallopian tube, you have this opening, essentially, so an infection that gets into the reproductive tract has the potential then to make its way into the peritoneal cavity. So this is actually showing us that, you get the normal radiopaque substance. So we've got open, we've got patent uterine tubes here, fallopian ducts, that actually are allowing this radiopaque substance to make its way into the peritoneal cavity.
What is the function of having it open?
It's just, the egg's got to get into the fallopian tube, and so we've got an ovary that's essentially covered over, it's modified, but it's covered over with peritoneum on that broad ligament. So it has to burst through that, and it has to traverse. Of course, it's held in place. There's a little fimbriated portion of that fallopian tube that's holding onto that ovary, and it doesn't have far to go, but it has to traverse a short distance across that peritoneal cavity to get into the fallopian tube. So everything in that area is covered over with that peritoneum.
So the egg actually transfers through that peritoneum?
There's a modification of the peritoneum over the ovary, but it has to essentially burst off the ovary through that tissue and traverse the peritoneal cavity to get into that fallopian tube.
And when that burst doesn't burst, it's a cyst, right? ovarian cyst. When the peritoneum doesn't burst when the egg is going through, that's a ovarian cyst, correct?
Could be, yeah. No, it's small cyst there. Okay. Good?
Mm-hmm.